to be at the back of the queue when a solution is available, but only available to some before others. Yet the world as we know it would be able to deliver to all at the same time. And I think that's the biggest lesson. The biggest lesson for African countries is, we knew vaccines were available, not just for COVID, for pneumococcal vaccines, for rotavirus, 20 years before we were able to introduce them for the children in our continent. And so for me, there has to be a push to decentralize manufacturing, such that we don't have some people at the back of the queue. Everyone should have access to what the best that science can provide and avail to global humanity, to the global population. Because, again, I think I like the lesson from COVID that what we call global health security means global health security for everyone. For me, I'm agnostic as to whether that service is then undertaken by Africans only or Africans with other partners, but it needs to be centralized such that Africans can access what science has to offer at the time that any other part of the world can access it. So if it means we open the continent to manufacturing, it doesn't have to be manufacturing by Africans only, but manufacturing on the continent, which means there will be availability and accessibility on day one, as manufacturing is happening elsewhere in the global north, for example. So that the fact that most of the health products outside of India maybe or South Africa have not been manufactured in the continent still means tomorrow, if we have another pandemic, the continent will be at the back of the queue. So I'm excited about what I'm seeing, with the Africa CDC, with the Africa Medicines Agency, but we need to accelerate availability, decentralization and availability on the continent so that we're not always at the back of the queue. Say in 2003, when it was said that HIV care and treatment could not be done, it was too expensive to get the medicines, to the costs that governments would take up, and it was too expensive to deliver. And if we took that then, we wouldn't have, millions of people on treatment, living healthy lives. We wouldn't have access to, prevention tools that, continue to reduce the number of new infections. So I think we have lessons, we have parallels to draw. And what the international community needs to do is exactly what we did in 2003, is say, no, impossible is not an option. We have to find a way to make, again, what the best that science has to offer available to those who need it. And I remember, back then engaging with manufacturers to really delve into these barriers, to availing treatment. And one of my colleagues said that, they were looking to a day when we would have treatment per patient per year be less than $100. It sounded, in 2003, it sounded like a pipe dream. Today, it's a no-brainer. We don't even talk about it. So it's doable. We just have to keep at it and, start from a point where it's impossible, it's not an option. If this is a tool that we know can, deliver for very many people who deserve it, why should we just, stick to impossible? And taking that radical stance is what the international community needs to do, is what African governments need to do. And today, I know that governments are willing to put in a lot more than they were able to then in terms of delivery. So if we can at least enable access in terms of a price that's affordable, then delivery is something that they're willing to take on.